Okay, so what I'm now going to talk about is detection of minimal residual disease in cancer patients. So, both fish and cytogenetics can easily see aberrations, but only when those are abundant in a population of cells. This is very suitable for diagnosis where cells are abundant. If you're going to do karyotyping, you need cells to be present, at least in 5 to 10% of the cells to be easily able to see those cancer cells. For fish, maybe 1 in 100 to 1 in 1,000 cells need to be positive. In cancer patients who have been treated, sometimes the percentage of cancer cells within the patient is much lower, and certainly during therapy, the percentage of cancer cells in the patient can be way down in 0.001% level. And we need to be able to detect and quantify these, and this is what we call minimal residual disease testing. So if we look at a typical leukemia patient, at diagnosis there might be 10 to the power of 12 cells in that patient, and when they're undergoing remission, that is apparently free from clinical signs of disease, they might still have 10 to the power of 9 cells within their body. Now that's an awful lot, and as soon as you take away treatment, then those cells will grow back. What we can see is different methods of detecting these tumour cells. Cytogenetics, FISH, flow cytometry and PCR all have different levels of sensitivity. Cytogenetics is the least sensitive. That can only detect when there's 1 to 5% of the tumour cells in the patient's blood that are abnormal for a particular chromosome abnormality, and that's because each and every cell has to be manually analysed by eye. FISH has a better sensitivity because you can have a few thousand cells on the microscope slide, but each individual cell has to be manually scored for how many copies of each chromosome are there and whether they are translocated, and you've got fused signals. Flow cytometry, this uses antibodies to detect rare subtypes, so this could be rare CD marker combinations that shouldn't be present in normal blood. This can scan maybe 100,000 cells, so you need about 0.01% of those to be cancerous to be able to reliably detect that cancer is present. Whereas for PCR, if done properly, it can detect down to 0.0001% of cells within blood being positive. And you think of a 10 ml blood sample having a few million lymphocytes, we can detect just one of those cells being positive in a 10 ml blood sample. Now this PCR approach, polymerase chain reaction, only works where we know the exact translocation. This is where one chromosome has broken and stuck onto another chromosome, and that gives a unique genetic signature across that breakpoint. And typically this involves disruption of a single gene, and we can use polymerase chain reaction to amplify effectively from one chromosome to the other chromosome and show that is an intact it is intact DNA spanning from one chromosome to another, and that indicates the presence of a translocation. So we're going to have to understand polymerase chain reaction to understand how this works. So if you've not already done it, what you should now do is pause the video and go and look at that polymerase chain reaction tutorial to understand how PCR works, and then from that point on we will explain how what we call translocation spanning PCR can work. Okay, so I'm going to go on to RT-PCR, so reverse transcriptase polymerase chain reaction to detect translocations. So before we go on to this is a reminder of what you have seen already, which is a typical translocation. Chromosome 9 and chromosome 22 have been translocated together to give this fusion chromosome. In doing so, that creates a fusion gene between the BCR and the ABL genes. That fusion gene creates a new novel mRNA which we can detect with our polymerase chain reaction. And we're going to do that, detecting that fusion transcript, by having one polymerase chain reaction on chromosome 9, one on chromosome 22, and that will amplify across this translocation junction. So this slide illustrates that translocation junction. So this is the DNA, BCR gene, ABL gene, and this is chromosome 9 fused to chromosome 22. This down here represents the protein, not the gene, but it represents the bits of this DNA and what it codes in terms of protein domains. That's not particularly important at this point. The key point that we do here is we have a forward primer in the BCR region on chromosome 9, and we have a reverse primer on chromosome 22. Now, because chromosome 9 and chromosome 22 are effectively fused together, when we try to perform polymerase chain reaction, we get amplification of all the DNA from here to here. Now, this from here to here will detect all variants of the BCR breakpoint. Sometimes it can break to create a protein like this, sometimes it can break and create a subsequent protein like this or this, but this set of primers will detect everything. These blue primers here, they're just coloured blue for the diagram, will detect total ABL protein, total ABL mRNA, sorry. So what we can do is look at the ratio of total ABL mRNA versus translocated BCR ABL mRNA and use that ratio to calculate how much BCR ABL transcript there is compared to background levels of ABL. Now, in normal people, there should be some of this. In normal people, there should be none of this. In cancer patients, we detect some of this and we can quantify that by quantitative polymerase chain reaction. Okay, so this allows us to do quantitative polymerase chain reaction. Now, polymerase chain reaction, normally you just amplify DNA and then you subsequently detect some product. In quantitative PCR, you detect the product as it forms every cycle. So this represents cycle number along here. So you amplify PCR for 40-50 cycles and you detect the product formation every single cycle. Okay, and we can detect the amount of product that's determined using a fluorescent probe, which I'm not burdened with you at this point. But what it can do is accurately tell us how many copies of the BCR-ABL transcript there are in a particular blood sample, and we can quantify that with standard curves. And here we can see an example where at cycle 15 amplification is readily detected. So this is a patient before treatment, this is a patient after treatment, and what we can see is after treatment we have got far less transcript, because the later the transcript is detected, the less of it there is, as we can see from this standard curve. Okay, just bear with me. So we can use this to detect what we call molecular relapses in PCR. So a molecular relapse is where you were treated the patient with therapy, the signal of BCR-ABL has completely disappeared, but then it comes back again, and we can only detect this by PCR. So what we can do is look at the ratio of BCR-ABL to ABL, and if it's negative, we find that the chances of a relapse is very, very small. If it's positive, it's almost certain to happen, and we tend to do this, in this particular example, 5 months after a stem cell transplant or other therapy. So what we're basically saying is we can detect very, very low levels of tumour cells in blood using this translocation spanning PCR, and it can predict who is going to relapse from that therapy. If we start to detect BCR-ABL positive PCR when we should have got rid of all the tumour cells, then that tells us that the tumour is likely to come back. So this is where we use translocation spanning PCR to predict who is relapsing from therapy. If we detect that someone's relapsing from therapy, you can then give them a different therapy. Now, this can detect patients much earlier than cytogenetics would. You need 1 to 5% of abnormal cells in blood to detect this happening by cytogenetics, whereas here we're detecting it when there is literally 1 tumour cell in every 10 ml blood sample. That is the sensitivity of translocation spanning PCR. PCR. This is a PCR that I performed, basically showing something very, very similar to that BCR-ABL, but this is using prostate cancer as the example. So here, what we've got is the TMPRSS2 translocation, which is present in prostate cancer. So the TMPRSS2 gene is fused with the ERG gene, and we're detecting the fused transcript by by polymerase chain reaction. So this is one of the most common translocations in cancer. This is only in prostate cancer, and this is because ERG is an oncogene, TMPRSS2 is a prostate-driven gene. So this is a positive control for the translocation. This is patient 1 and patient 2, and these are detecting circulating prostate cancer cells in asymptomatic patients' blood. So the patients have got apparently been not so much cured, but they are, as far as they're concerned, they are tumour free. But what we can detect within their blood are very, very small amounts of TMPRSS2 fusion transcripts, and that is coming from either tumour cells in the blood, or it's coming from mRNA released from wherever the tumour is in the body, and we are detecting it in the blood. So this is just using that translocation spanning PCR in a different situation. This is solid tumours, this is prostate cancer, and that normal healthy young male is actually my sample. These are 2 patients with moderately advanced prostate cancer, but as far as we were concerned, they were under control, but we could still detect tumour cells within those patients' blood.